Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Grand Rounds this week, where Dr. Shane Leyen, a PGY3 anesthesiology resident here in Saskatoon, presents on the management of epidural catheter disconnections. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
For those of you that don't know me, my name's Shane. I'm one of the third-year residents here, and today my Grand Rounds topic is going to be on epidural catheter disconnections. May not seem like the most riveting topic, but I thought it seemed a little timely. I selected this topic because I had never really heard of it before the start of my third year here and hadn't really considered reconnecting them at any point, so kind of took a bit of a deep dive into the topic. And from our resident group chat, it seems like this is kind of a bit of a growing issue, so figured it could be useful for everyone. I want to give a couple of big thank yous out. First to Dr. Alex Pellerin, who did a presentation on this topic at Talk Rounds a little while ago, and I borrowed a good amount of content from her slides, so thanks, Alex. And then also to Dr. Murray Deese, who provided some guidance along the way. I'd also like to start with acknowledgement here. So I acknowledge that we live and work on Treaty 6 and Treaty 4 territories in the homeland of the Métis. Get into our learning objectives. So I'm going to review some literature, or what literature I could find surrounding epidural catheter disconnections. Next, we'll kind of discuss approaches to the disconnected epidural kind of across the world. We'll discuss some strategies to prevent epidural disconnections, and then we'll review local practices, guidelines, and protocols. So for a little bit of background, epidural anesthesia, as we all know, is widely employed for labor analgesia and postoperative pain control. Epidural catheter disconnection is a relatively common complication, and there's quite a wide practice variation in response to disconnection by anesthesiologists everywhere. So, and it's also almost part of a conclusion, but there is a paucity of data kind of available to guide clinical decision-making following these epidural catheter disconnections. And I apologize if my voice sounds a little raspy. I'm battling a bit of a cold right now, so I might need to throw a cough drop in at some point. Just to make sure we're all on the same page, when I refer to catheter disconnection, I am referring to the catheter itself. I'm not sure if you guys can see my mouse, but the catheter itself being disconnected from the hub, not the hub being disconnected from something more distal, rather tubing or bacterial filter. Just kind of set the stage a little bit, and we won't be submitting questions to a survey or anything, but just kind of do it in your own head. I want to present a couple scenarios. So in our first scenario, we have a healthy 23-year-old prurient, previously well-functioning labor epidural, now developing more pain. So to assess the patient, you find the epidural catheter has been disconnected maybe an hour. I think everyone would kind of think, what would you do in this situation? Just reconnect the catheter, clean the outside and reconnect the catheter, cut a portion of the catheter and reconnect, maybe clean the outside, cut a portion and then reconnect, or would you just yank the catheter out? Maybe a more complex patient here. So 85-year-old woman, post-op day 2, open right middle lobectomy, history of severe lung disease, severe COPD, untreated OSA. Epidural most recently assessed at the evening nurse shift change at 8 p.m. the previous night, and now it's found to be disconnected at 8 a.m. So really unclear how long this epidural has been disconnected, and the catheter has been disconnected. Patient's now experiencing much more pain, not able to move in bed, and hasn't really started any real oral intake. So quite a different situation that changed what you do. I'll dig into things a little bit. So the first learning objective, we're going to review some of the literature I could find surrounding epidural catheter disconnections. Start with how common is it? Some studies quote the rates as high as 5 to 11%. Others are lower, closer to 3%. A bit of a confounding factor here, something that makes it more difficult to analyze, is there's been a change in the style of the connector design. So the clamp connector, which we commonly use, or the only one I've ever seen at our centers, is quite a bit less prone to disconnection versus the older style, the screw cap connector. Why do we care about this? I'd say the most chief concern here would be infection. Well, these are quite rare events. They are associated with catastrophic sequelae, as we all know. There's a spinal epidural abscess. To date, quotes a rate following epidural catheter placement of 0.5 to 3%, which is quite a bit higher than I would imagine. But in relation to just the obstetrics population, it's quite a bit lower, so 0.0004%. And of note, case reports have found both infectious complications in both non-aseptic and aseptically performed neuraxial procedures. So it's not entirely effective doing it aseptically, although maybe those procedures were not as aseptic as they were thought to be. We'll kind of dive into what happens to a disconnected catheter next. So this is one study, and their whole goal was to determine if disconnected catheters could be safely reconnected. And I think this was from 96, so a little while ago. So in this study, they took epidural catheters, filled them with a saline fentanyl solution, then they injected bacterial into the distal end. So in vitro study, so after 8 hours incubating at 40 degrees Celsius, they did displace the fluid proximally. So they essentially drained fluid out by gravity. They found that the bacteria could be cultured almost up to 90 centimeters more proximal, and that the bacteria is actually cultured more proximal than the fluid level displacement, so farther than the meniscus was displaced. That was only if the fluid was displaced more than 32 centimeters. So we can ask, well, will the fluid be displaced proximally? Do we need to be worried about this? It's dependent on a variety of factors: patient positioning, catheter end relative to the patient, as well as the epidural space pressure. The same study looked at in vivo portion of their study, and they found that if indwelling catheters, so they have to use patients, had disconnected catheters extended vertically, there is quite a significant amount of fluid displacement. And that fluid entered the epidural space in more than half the patients. That was just following 1 hour. So we already talked about what happens if the fluid is mobile. The meniscus moves distally, or proximally, I should say. But with the fluid static. So in vitro, again, after 8 hours incubating at 40 degrees Celsius, if they cap both ends immediately, there's no growth bacteria beyond 20 centimeters, and this is completely regardless of catheter position. So we'll kind of compare that to fluid being displaced proximally, can culture bacteria very proximal, but if you capped it, not culture the bacteria more than 20 centimeters. I think a few caveats with this study would be that they did inject bacteria into the ends of the catheters, which none of us are doing. As well as incubating the catheters at 40 degrees Celsius, which doesn't really replicate real world situations, as that's not the temperature of the catheter to be seen outside of the body. Next question they wanted to ask is if cutting epidural catheter can be sterile. So they took these catheters, they filled them with a solution that promotes bacterial growth, and it's just soaked the external parts of these catheters in Staph aureus suspension for 5 minutes, and soaked them in betadine for 2 minutes, let them rest in room air for a few minutes, cut them with a sterile blade, and then they perfused these catheters with that same hydro solution, tried to incubate any bacteria out of there, and cannot have any bacterial growth out of any of their samples. So their conclusions from this study: I found that following disconnection, there may be an area of the epidural catheter remains sterile for at least 8 hours. And that's pending if the fluid in the catheter does remain static. So it's not, the meniscus level is not changing. And they concluded that catheter exterior could be adequately cleaned to prevent bacterial entry from cutting and reconnection. Look at another study now. And this study, they wanted to mimic the movement of contaminants along a sealed catheter. And I think a few people might have seen this, the results of the study before, but this is where they took epidural catheters, filled them with normal saline. They clipped the catheters of the patient end and essentially sealed them. And then they introduced fluorescein dye at the distal end and then capped it. So they did not inject the fluorescein dye. They kind of just tried to create a fluid interface between fluorescein and normal saline. So in vitro at 6 hours, I believe room temperature, and they had all the catheters horizontal, they're capped at both ends, and they had a maximum bit less than 2 centimeters traveled by the dye, would be the maximum. Although you can see there's quite a wide variability in terms of that distance tracked by the fluorescein dye between the different catheters. Their conclusions is that by capping, some of the previous authors' conclusions, that movement would just be dependent on diffusion. Their suggestions that were that if a disconnection is discovered, the catheter should be cleaned, a length removed, potentially 10 centimeters, they weren't entirely clear, and then capped. And the reasoning being that this should be sufficient to prevent further ingress of contaminants, caveat being that if contaminants behave like fluorescent dye in normal saline. This is all in the context of the decision has been made to discontinue the epidural, but it cannot be immediately removed due to VTE prophylaxis, or recent VTE prophylaxis administration. Another study here. So they looked into a few clinically applied safety measures after epidural catheter disconnection. So they took empty epidural catheters. They had a luer lock connector and bacterial filter attached to them, and they vertically submerged these into a bacterial suspension, a couple centimeters. They then applied a few different safety measures that may be commonly employed, such as cutting. They just did 2 centimeters distal to the level of contamination. This was immediately after they were dipped in the bacterial solution. Simply disinfected the end, or they flushed them with ropivacaine. So after 24 hours of incubation at 24 degrees, all the cut catheters remained sterile. Disinfection prevented only 6 of 40 infections, and ropivacaine did not prevent any growth. Admittedly, I haven't seen or heard of ropivacaine before being used as a sterilizing agent. Their conclusions was that just cutting 2 centimeters distal to the level of contamination did completely prevent bacterial growth within the catheter. Disinfection could further reduce the risk, and they think that their findings support catheter shortening and reconnection following disconnection, although the safe timing and the length to remove remains unclear. I think a few caveats being with this study is that they had empty epidural catheters, and that the bacteria might behave differently when there is a fluid interface rather than an air interface. But it did show that cutting did prevent bacterial growth in this study. Next, we'll move on to what are other anesthesiologists doing. So a lot of these are just surveys from around the world. So this one's out of Liverpool, 2000. They did a departmental audit into the management of disconnections. Many people are happy to clean the end and just simply reconnect if it was witnessed. If it was unwitnessed, the tendency would be to remove the catheter. Many respondents were unsure, and I don't have actual percentages from this article. A lot of hesitation surrounding the timing of VTE prophylaxis, and this survey or audit is what prompted the study with fluorescein we previously discussed. This is a survey of Canadian anesthesiologists from a bit over 20 years ago, and similar answers or responses that I included with the initial scenarios I presented to you. But when a disconnection occurs, the vast majority would clean the outside, or I'd say the majority would clean the outside, cut a portion, and then reconnect, followed by most people removing the catheter. Only 2% would just straight up reconnect the catheter. Same survey asked about departmental policies. 22 respondents said yes. The article was unclear about how many said no. And interestingly, there was not always consistency between the actions taken, both within and between centers, and in regards to the actions taken relevant to a departmental policy. 14 of 75 respondents did state that removing the catheter was because they were following a departmental policy. This is a survey out of Scotland. Pretty similar results to the Canadian study in terms of catheter disconnect and had contact with bed linen. Half the people would clean, cut a portion, and then reconnect, and then 44% would remove the catheter and then plus minus insert a new one. And just 6% would clean the outside, reconnect the catheter. In terms of the length of catheter removed, most people would remove less than 5 centimeters. About a bit under a third would remove 5 to 15 centimeters. Only a couple percent would remove more than 15 centimeters. And they also went on to kind of discuss factors that would favor removal or reconnection. Factors favoring removal, the unwitnessed prolonged disconnection, macroscopic contamination, catheter or bed linen. The epidural was cited perioperatively due for imminent withdrawal, providing suboptimal pain relief. I think a lot of things that would already be going into our minds already. There's factors favoring reconnection. I think a lot of us will agree with these if they're severe respiratory disease, recent thoracotomy or laparotomy, ongoing labor, if it was a very difficult epidural insertion, and previously providing good pain relief, for example, or prior anticoagulation. During my digging, I found that there is actually a practice advisory for the prevention, diagnosis, and management of infectious complications associated with neuraxial techniques. It's a bit of a mouthful, but this is a report from the American Society of Anesthesiologists Task Force on Infectious Complications Associated with Neuraxial Techniques and the American Society of Regional Anesthesia and Pain Medicine. Simplify this, we'll be calling it ASA and ASRA. From 2017, my question was in response to immediately remove accidentally disconnect catheters. The consultant surveys are expert consultants that the advisory group reached out to, and the ASA membership responses are just random ASA members that the survey was sent to. So I found when looking at this, it looks like kind of an even spread, but if you combine the agree and strongly agree and the disagree and strongly disagree, it shows, I don't know, I think it highlights the difference or the disagreements more between the expert consultants who disagree with that statement in general or equivocal, whereas the ASA members in general are pretty evenly split about what to do. A bit more from the practice advisory. So they do a literature review in response to this kind of statement or question, and they found that the literature is insufficient to evaluate whether removal of an accidentally disconnected catheter is actually associated with reduced frequency of infectious complications. Survey, as we already discussed, ASA members are equivocal, consultants disagree, but with that in mind, the task force believes that in order to avoid infectious complications, an unwitnessed accidentally disconnected catheter should be removed. I found their advisory statement was a bit less strongly worded in that they said, consider removing unwitnessed accidentally disconnected catheters. I just want to do a quick note on ASA practice advisory. So these are intended to assist decision-making, summarize the literature, reports, member surveys, expert opinion. But importantly, they're not standards nor guidelines, and this is due to a lack of sufficient numbers of quality, adequately controlled studies, and they are not intended to replace local institutional policies. I just wanted to include a few other things that I found interesting from this practice advisory, some things that I kind of had just accepted as, I guess, true or fact. So in regards to aseptic techniques, there's actually insufficient evidence regarding the efficacy of them, such as removal of jewelry, hand washing, wearing of caps, masks. I thought wearing of sterile sterile gloves was interesting. Despite that, and which I think seems quite reasonable, is that they still advise that aseptic techniques should always be used, although they do leave out wearing sterile gowns in their advisory, which I haven't seen anyone do. In regards to the occlusive dressings, there are no comparative studies, and observational studies have found that pelvic cultures still occur with use of occlusive dressings. Despite that, use the occlusive dressings, again, relatively inexpensive. Seems pretty reasonable to me. In regards to bacterial filters, which I also had just imagined would likely reduce or prevent positive cultures from the catheter. They found that they definitely do not prevent and may not actually reduce any positive cultures. So the advisory is only consider them during prolonged or extended epidural infusions. And then another interesting thing is duration of catheterization. So observational studies have found that infections are associated with longer durations, but no specific safe or more dangerous duration has been identified, and they just advise the catheter should not remain in longer than necessary. So this is that same Scotland survey where they talked about or investigated what preventative measures their practitioners use. This is the tug test following insertion, making sure that a sudden pull does not result in disconnection. It was the most commonly employed prevention measure in the survey. And I haven't really thought about this before, but I think I might just intuitively or automatically do it when I am placing an epidural. Pay attention next time I do it, but I feel like normally insert it and do give it a little tug. Unclear to me how much force you should be applying. But I also hadn't heard of this ever before, so I thought it was kind of funny. This is out of Texas, but published in the CJA, and something a lot of us have probably heard of is simply taping the flag to the connector. And they did not give stats, but they said since we began using this technique, we have had no problems with epidural disconnections. And this is out of Japan in 22. I call this the aggressively taping method. As you can see, they tape it up and then down and tape it pretty aggressively a bunch. And they found their disconnection rates without the aggressive taping method were 6.5%, which again, that's like 1 in 20 people. That's more than 1 in 20 people. That's higher than I would expect. Excuse me. And 0% disconnection rate with this taping method. And they actually looked at the force required to cause a disconnection with the two different methods. And out of Texas in 97, they call this a simple system to prevent epidural catheter hub disconnections. I'm not sure I would describe it as entirely simple. So what they do, similar to us, they secure the catheter to the hub, they tape it up to the shoulder, but they then connect the hub to a 30 centimeter arterial line extension tubing, take all the loose catheter, the hub, and the start of extension, coil it up, place it on a gauze, and then cover that with a super large dressing, such that the only thing that's exposed is the end of the arterial line extension. The reasoning being that this then protects this entire, hub component from contamination, and that if or when boluses are being given or the bag is being changed, there's much less force being applied directly to the hub, such as anytime we give a bolus, we disconnect things and we're yanking on stuff. So would definitely require a bit more time involvement from nursing colleagues, as well as getting a lot more equipment up to obstetrics if we were to implement something such as this. Moving along, and I'm going pretty fast here, so I might try to slow down a little bit. But I'm hoping we have a little bit of time at the end for some discussion. So in terms of local practices, guidelines, protocols, we'll start with local guidelines and protocols, and I think kind of local practices will more be something we discuss afterwards. So I tried to find any anesthesia department specific protocols, and hopefully someone can correct me later on if I'm wrong, but I was unable to find any, or was unable to find anybody who was aware of any. I then found this portal on the SHA website called the Policy and Clinical Standards Document Finder, which allows you to search for different policies across the province. Looking SHA-wide, couldn't find anything particularly relevant. Looking specifically at the former Saskatoon Health Region policies, I did find a few nursing policies. And the three of them being epidural catheter, assisting with insertion and care of. And they have a note that if the catheter does become disconnected from the adapter, call the anesthesiologist immediately, but that there is no need to clamp that catheter. They have a care of patients receiving epidural intrathecal analgesia policy, no mention of disconnections during that. But in their catheter removal protocol or policy, They do note that the epidural infusion may be stopped and utilizing sterile technique, the epidural catheter capped with a sterile dead end. If removal of the catheter must be delayed due to anticoagulant administration. So this is something they do in regards to VTE prophylaxis. My general thoughts, approach. I didn't include a big formal conclusion as per se, just because I feel that there is very limited strong literature on what we should do, but these are kind of my takeaways. So in regards to prevention, I think it's pretty reasonable, and I think the evidence is good that we should be affixing all catheters to the connectors, whether it's an epidural sticker, tape, tegaderm, whatever it may be. One study showed that this does increase the force or required to disconnect the catheter from the hub. I think the tuck test seems reasonable, although it's unclear the amount of force that should be applied. And I think a lot of us might be doing this already without really thinking about it. I wanted to show a quick couple pictures from locally. So on the left here, we see someone did apply tegaderm, but this isn't necessarily the point of weakness. Hopefully you guys can see my mouse. But the area circled in red here is the area of weakness. So if we were going to secure it, we really want to make sure we're securing the hub to the catheter. And I can't remember where I got this picture on the right. I think it was from the anesthesia resident group chat, but this is above and beyond. So they do the epidural catheter tape, additional tape, some tegaderm. So this is what you want to do. You want to secure the catheter to the hub, not the hub to the tubing, if that makes sense. In terms of what I would do if I'm notified by nursing, I'd probably clean the catheter end. And my thoughts being that this prevents or at least reduces further proximal fluid displacement. And so if there is contamination already at the end of the catheter, it's not now transmitting all the way proximal towards the patient. And this buys us time to think about what our next action would be, whether it's sterilizing the epidural, cutting it, if we want to remove it, and we need to wait until an adequate time has passed since recent VTE prophylaxis administration. So I do think this cleaning, capping the catheter end, could this be performed by our nursing colleagues if accidental disconnections? Should it be? Their current protocols say that there is no need to clamp or cap the end. Although, as you saw, with the removing protocol, they already do sterilely clean and cap the end. So I don't think it would be a huge leap for them to do this if it does become disconnected accidentally. It's an unwitnessed disconnection, and again, these are my thoughts, and I'm not here to critique other people's practices by any means, but in my mind, I think if there's been an unwitnessed disconnection, an unknown amount of time, I think contamination of the catheter can be assumed. And to myself, it's unclear how to accurately determine a safe length of catheter to remove. I don't know what the catheter end position was during this disconnect. I don't know how far approximately the meniscus has moved. In my mind, I wouldn't place a non-sterile epidural catheter if I dropped it on the ground or if it falls off the tray by accident. I just ask for a new one before seating it. So infusing through a non-sterile catheter feels analogous in my mind. With all this said, I do favor epidural removal in such a situation, but this is definitely pending the clinical situation. It's a witness disconnection. I think if it's immediately cleaned and capped, I think it's pretty reasonable in my mind to sterilize, cut a length, and then reconnect, or if we know it's been a very short amount of time, for example. In regards to a departmental protocol, I'm saying this with the thought being that we do not have one. We already have one. I think it's a great idea. But if we don't have one, I don't know if we need to develop one. The reasons being, I think there's a lack of supporting evidence for the various approaches and a lack of evidence that removing them actually reduces infectious risk, although lack of evidence is not proof of absence. I also think that protocols and policies, especially as clinicians, and these fail to appreciate or recognize the nuances of the entire clinical situation, to potentially push clinicians into decisions or situations that may not be in patients' best interests. If that makes sense. Back to our scenarios. We take a moment to kind of think over these again. Our first scenario was that healthy 23-year-old parturient, prime, previously well-functioning epidural, now experiencing more pain. When you went to assess them, the epidural catheter has been disconnected. Expect maybe an hour because it had been working well, and they're just starting to develop more pain with contractions. So maybe about an hour. In our second scenario, which is a more complex, or in my mind, more complex situation, the 85-year-old post-op day 2 had thoracotomy, severe COPD, untreated OSA, epidural has been disconnected an unknown amount of time, really just assessed between the two nursing changes, so about 12 hours apart. Now they're getting a lot more pain, are able to mobilize, haven't started consistent oral intake. I guess if we wanted to make this a more complex situation, we'd also say that it was a very difficult epidural to place.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.